Good afternoon all. Welcome to our second session. Today we have a topic on introduction to pain taken by Dr. Anne. So we can start with ma'am's presentation. We can have it for around 40 to 45 minutes followed by 15 minutes of discussion. By 4 we can have our case presentation followed by its discussion. By 4:30 we can wind up our session. Thank you all for joining in. Over to Sunil sir.
Good afternoon, everybody. So today we have a very important topic, which we usually see in patients with chronic illness, pain. This is only an introduction to pain. So this session will be handled by Dr. Anne Broderick. Dr. Anne was Director of Hospice and Palliative Care Program at Iowa University. After retirement, she is now the Director of Hospice and Palliative Care Program at VA Medical Center, Iowa City. Dr. Anne has been visiting us frequently, and she has been palliative care for many years. Welcome, Anne, and so to you.
Thank you, Dr. Sunil. And I have been doing hospice and palliative care for over 30 years. I'm looking forward to learning from people in PMR over this session. So I'd like to start by introducing myself. I started as a hospice medical director in Iowa City, then became the director of palliative care at the University of Iowa, as Dr. Sunil says, and then also decided that I wanted to start another program at a different hospital, the Veterans Administration Hospital in Iowa City. So it's a pleasure to be here. I'm sorry. So I want to make sure that you know that we're not going to answer all your questions about pain today. It's simply an introduction to describe pain in ways that are consistent with palliative care and classify it. I think of the assessment of pain as something that needs a great deal of attention in palliative care. Thank you. So let's start with thinking about Ms. Swarnaprabha. Sorry if I've mispronounced that name. She's a relatively young woman, premenopausal, with advanced cancer of the breast, and she is currently in pain. She is a wife, mother of 2. She seems to respond partially to medications, but has poor adherence to treatment. I usually run my talks very interactively. What do you think might be causing her pain? And if you just raise your hand, then I can unmute you. What is causing Swarnaprabha's pain? Any ideas?
Yeah, anybody?
Anybody have an idea? Why does she have pain?
Please be more interactive.
I'm a palliative care physician, so I'm okay just sitting here. Yes, yeah. Can I hear from that? Can you unmute? Yeah. There we go. Okay.
Yes.
We're ready to listen.
Maybe because of mass effect caused by the cancer.
Sorry, can you come more closer to the microphone?
Possibly mass effect caused by the tumor.
Okay, exactly. First, the obvious is that she has a mass effect from the tumor. What else?
Psychological thing because breast cancer at the age of 32.
did somebody say having breast cancer at the age of 32?
Psychological factor.
Exactly right. So she's facing that she has advanced cancer, probably uncurable, and she's only 32 years old. What else is causing her pain?
Invasion to the intercostal nerves. It's an advanced cancer.
Infiltration of intercostal nerves.
Oh, absolutely. She could have, I'm just repeating what you said, make sure everybody hears. She could have the infiltration of the nerves.
Bone metastasis.
Sorry, we didn't hear properly.
Bone metastasis.
Bone metastasis.
Bone metastases, yes. When they resected the cancer, what might they have also resected out of her axilla? They might have taken lymph nodes out of her axilla, causing lymphedema, another cause of pain.
Cells following radical dissection of lymph nodes.
Correct. The dissection of lymph nodes could have caused pain in addition to lymphedema. Why else might she be in pain?
Treatment is not effective also, right?
Sorry?
Yeah, pain, the medicine is not inadequate treatment.
Inadequate pain relief because she's not taking the pain medicine. What else? Can you think of anything else?
Centralization of pain.
Centralization.
Correct. Untreated, ongoing, untreated pain can escalate. Absolutely right. She may have lost intimacy with her husband by virtue of having breast cancer. She's had lots of losses and she's worried about what's to come. I think we've handled things pretty well. Let's keep going. So important to realize that pain is a sensory experience, but very important to think about it as an emotional experience as well. So almost, I can't think of a pain that doesn't have an emotional shroud or an emotional experience that surrounds it. And this varies from person to person and from time to time. So important that we realize that it's an emotional experience and the emotional experience amplifies the physical pain. So there is clear physical pain in this patient, but there's also the amplification of pain through an emotional experience. Does anybody want to share an example of when they've had pain and they've had an emotional component to that pain? If you don't, I have one. Any of you that have been quiet up till now, can you think of the last time you had pain? Was there any emotional component to it? I'm very happy that none of you have had pain that has an emotional component to it. I'll tell you a interesting story about myself. I was hiking here trekking here in Kerala, and I fell. And I fell, and I fell and landed on my wrist. And the day later, I started having pain. And I worried, oh, do I need to go to the hospital? Oh, do I need an x-ray? And I worried and worried and worried and worried, and the pain got worse with every day of worry. And luckily, I eventually talked to a physician, and he said, "Why are you worried? Nothing happened. It's not broken." And then the pain disappeared. So I amplified the pain for days with my emotions, and then it got better. So one lesson that I'd like everybody to think about when they think about pain is that pain is what the patient says it is. Now, in the US, we saw a opioid epidemic because we not only believed the patient, but we gave them very strong pain medicines. When I say believe the patient about the pain, it doesn't mean necessarily give them heaps of medication, but listen and assess their pain in all of its components. Okay. Am I doing okay with my English? Are you understanding my American style English? Thumbs up, thumbs down. Everybody okay? Okay. I'm glad everybody's all right. I'm glad all of you had your thumbs up. Okay. So Cicely Saunders is the founder of the hospice and palliative care movement from the UK, and she coined the term total pain to describe exactly this, that people have, can I go over here? This is point? I just want to point. This one?
Yes.
Oh, that doesn't go okay. Okay, that's fine. To describe physical pain, which is what we all associate, that's fine. We'll all associate with pain. But also we need to identify what else happens when somebody has an advanced illness of any kind or trauma, which I understand would be more important to PMR physicians. So there's a social change, as there is for this breast cancer patient. She's no longer able to fulfill all the roles that she has in her family. She's no longer able to work, so there are financial endpoints. And there's emotional difficulties and spiritual difficulties. So the spiritual does not necessarily mean religious. It's the sense that she says, why me? Why, when I'm 32 years old, am I given this terrible diagnosis? Why am I carrying this burden? What's the reason for me to be in this world if I'm going and have children, if I'm going to die at the age of 32 or 33? So this is what Cicely Saunders called total pain. And the objective of our treatment in palliative care and in every other field of medicine is to improve the quality of somebody's life, not just relieve their physical pain. And it's been my experience, and this is why I have gray hair, is that if I only address physical pain and I don't handle the other layers of social, financial, spiritual pain, I will not get pain relief. I need to address it all. So one of the most exciting parts of Cicely Saunders' legacy, she's now, she died several years ago. Her legacy is that when she addressed total pain, her doses of pain medicines, especially opioids, was very low in her hospice because she treated all the other kinds of pain. She didn't need high-dose opiates, much of what we saw in the later periods in the US. She was able, because she did addressed all these pains, that she didn't need such high treatment for physical pain. So I'm sure that this is a review for people in PMR, but I want to make sure that we're all talking the same language. One type of pain, nociceptive pain, starts in the somatic. So somatic pain is a type of nociceptive pain and refers to the pain that comes from joints, skin, bones. And bones is a little unusual because bones has both nociceptive properties and neuropathic properties. Also, visceral pain, which is pain from hollow organs, often it's referred. So the pain of a myocardial infarction is a visceral pain. It's also menstrual cramps would also be a visceral pain, often poorly localized, whereas somatic pain is very easily localized. People can say, can you point with one finger? Often when somebody can point with a single finger, I understand that to be somatic pain. Visceral pain, you can also get visceral pain from the expansion of the liver. If the liver is filled with tumor, you get expansion of the visceral layer of the liver, and that can also cause visceral pain. Irritation of the diaphragm can cause pain up in the shoulders. These are different kinds of pain. So neuropathic pain is really a disorder of the nervous system and is often quite sharp, quite intense. It's the pain that you get if you hit your funny bone in the wrong way, and it's very intense within seconds. Ischemic pain can have neuropathic components. So if somebody doesn't have a good blood supply to their feet and develop ulcers, they have a combination of neuropathic and nociceptive pain. And I think ischemic pain is among the worst combinations of neuropathic and nociceptive pain. As I mentioned, psychological or emotional pain can amplify other pain. So anxiety and worry about your physical pain can make it worse. Spiritual pain is not, sometimes people shy away from this term because they think it has something to do with religion or faith, but really it's why are things happening? Why is my world order being turned upside down? And in our case of the woman with breast cancer, we see that she has the distress of lost relationships. She's unable to play with her children. She might not be able to be intimate with her husband. She's unable to work. She's lost so many of her relationships. The truth is that most patients, I wouldn't even say often patients, but most patients have a mixture of different kinds of pain, often need a good comprehensive approach. So if you're thinking about doing a pain assessment of our young woman with breast cancer, what's a tool that you think would be really important to have? What tool should you make sure? I'm going to ask somebody who hasn't participated yet to jump in and tell me a tool that that's needed. Sharina, can you help me with what tool, if you're going to do a pain assessment, what do you want to make sure to have? Can you think of anything that should be really important? I'll take a sip of chai while you're at it.
Okay, so for pain assessment tool, do you mean the various scales we have? Or?
No, scans, did you say?
Scales.
Scales. That's a good answer. So you want to make sure to have some scales for pain. Okay, I'm going to let you, that's a good answer. Anybody else? Any other thoughts?
The patient self-report regarding his pain, the regions of pain and his symptoms.
Say that again, I'm sorry.
the patient self-reporting system about his pain and his various features like fatigue and other symptoms and the distribution of pain?
Yeah, so you're going to be asking about where the pain is and any other symptoms. I'm going to answer my own question because I want you to see that the most important tool for your pain assessment is a chair. You need to sit down. I'm being silly. I'm sorry. You need to sit down if you, all right. You need to sit down if you're going to be able to listen. All right? You can't stand, here I go. You can't stand like this next to the patient and expect a patient to share what's going on in their lives. Okay? I'm sorry, Sharina. Am I forgiven?
Yeah, that's perfectly fine.
Okay, thank you. So I think the most, and I carry, in my hospital, I carry a chair with me. I carry a chair so that I can sit down. I make sure that any learner with me also sits down because the quality of the conversation is better and you don't spend more time if you are sitting down. Okay, all right. Thank you for putting up with my small joke, but it's actually a very important component. And I have to say that here at TIPS, we make a very big point of sitting down when we're talking to patients as well. All right. So the pain assessment, sometimes when I say, tell me about your pain, patients say 5, or they say 10. And I say, no, that doesn't help me. I need to know more about the pain. I don't need a number, but can you tell me about your pain? You can see all the boxes that I am listening for, but I do not do a checklist method. I don't say, tell me the quality, tell me when it happens, tell me where it goes. I don't do that. I sit back with my pad and I say, tell me about the pain. And then I go, uh-huh. Or, yep, keep going, keep going, keep going. And I listen for different things that I need to hear. So what am I listening for when I say quality? What am I listening for? Any ideas? You can tell I'm not going to give this lecture, you're giving the lecture. Any ideas on quality? What does that mean?
The type of pain?
The type of pain. Sometimes people say, can you describe this pain without saying pain? And what do you sometimes hear? What are your PMR physicians, what do you hear about pain?
Can be throwing or burning.
Oops, let's try one person. Is it seafood?
Pricking type of pain.
Okay, a pricking type of pain. What else? So, what else?
Dull aching. Dull aching.
Dull or aching pain, throbbing pain. What else?
Lancinating pain.
Lancinating pain, shooting pain, very similar.
Piercing. Stabbing.
Stabbing, cramping. These are all qualities that are very descriptive and very helpful. What are we listening for when I say temporal?
Time.
The diurnal variation?
Time.
Oh, okay, diurnal variation. That is it worse in the morning or worse at night? What else?
The duration?
Okay, we'll talk about it, whether it's radiating later. What else?
Is it disturbing the sleep?
Disturbing sleep? Is it nighttime? How far back did it start? When did it start? Okay? Radiation is, where does it go? Or does it stay where the finger is? Or does it travel? Okay? What makes it worse? What makes it better? You want to make sure that you get that. And when does it happen? Does it happen when I'm in bed, when I'm on my left-hand side, when I'm on my right-hand side? When does it get worse? And more importantly than all is the functional impairment. But I don't think I have to say that to PMR physicians because you're always looking for function, right? So is she able to sleep? Is she able to work? Can she do ADLs, activities of daily living? And then finally, what medications have you taken? Any questions about, and you can see if you, that there's a mnemonic of PQRSTU, all right? U is for function. Right. If you like mnemonics, that might work for you. And this is a different way of presenting the same information, which is that somatic pain is very localized. The descriptors are aching, gnawing, deep, dull, sharp, and stabbing. The visceral pain can also have some sympathetic discharge with it, such as nausea and sweating, and usually described as squeezing and bloating, but is often referred to different sites. And neuropathic pain is, the cause is usually damage to a nerve or bone, and all those descriptors that you mentioned are all there. And in addition to being radicular, this is the classic neuropathic pain of sock and glove distribution that we see in patients with undertreated or even optimally treated diabetes. So she's not taking her morphine. Can you think of why? And this describes it. So I don't have a watch. Oh, we'll move the clock into your house, into your room. No, I don't like looking at the clock. Why don't you like looking at the clock? Because it tells me that time is passing and I shall die soon. So she's clearly overwhelmed with grief, anticipatory grief, in addition to already mourning the losses that she's experienced in her life. Tell me, in India, why don't people take their tablets? Why, in your experience, don't people take their tablets?
Scared of the side effects.
Because they forgot to take.
They forget to take it? And what else did you say, Sharina?
Side effects, because everyone is, whenever we prescribe, they are scared of the side effects. The first question that come around is about the side effects of the drug.
Okay, so they've read the side effects, or the people have told them the side effects, or they're worried if it's an opioid that it might cause addiction. What else? What other reasons do people not take medicines?
They may be following other system of medications.
People can't
Like,
afford to buy all the drugs they are prescribed.
Many can't afford buying tablets.
Okay, so there's really a financial piece that they can't afford the tablets, and so they don't take them. They're fearful of certain kinds of tablets, so they don't take them. They're fearful of side effects, including if it's an opioid, they might be fearful of addiction. I hear this in the US as much as any place.
Dr. Shareen?
Yeah, here in India, they follow other system of medications like Ayurveda or something, who advises them not to take any allopathy medications along with it.
Okay, they're getting different advice from different practitioners. In this case, an Ayurvedic doctor will think of medications as not a good idea. So there are lots of reasons people don't take their tablets, and it's good to explore why people are not taking their tablets, absolutely. Okay. I think it is helpful to think of a distinction. Again, I don't think this will be a surprise to all of you, but acute pain is really quite a different phenomenon than chronic or persistent pain. Chronic or persistent pain is, we just define it arbitrarily as greater than 3 months, and that the original injury may not even be there anymore, and they'll have difficulty localizing the discomfort. It might be more difficult to point with one finger, and they use a whole hand to point to the area, or a whole hand to point to things, because it's so difficult to really identify it. And in this, I think over the last 2 decades during my career, the recognition that persistent and chronic pain is different than acute pain is probably the most important change in my practice, is understanding that these are 2 different entities. They shouldn't actually have the same name because they're very different. So if a stimulus continues and it is constant, what would you say? So as time passes, would the pain remain constant, decrease, or increase? If the stimulus continues to be constant, then there is ongoing stimulus, and often your pain increases. The natural history of acute pain is that it decreases, but if the stimulus remains, it often will increase for the following reasons. One is the recruitment and sensitization of peripheral nociceptors. So the nociceptors that are surrounding the initial burn of your finger or whatever are now recruited. This doesn't happen automatically, but it can happen, and the recruitment can also happen in the central nervous system at the spinal and brain level, so that you're recruiting additional spinal segments and this will often increase pain. So the chronic pain is a different entity. Again, I mentioned the peripheral sensitization, which could decrease with prostaglandin inhibition if it's given in time. And then finally, the phenomenon of wind-up, which is NMDA mediated in the central nervous system, can lead to worsening pain and decrease in effectiveness of opioids. I think I'm moving too fast. So my learning points are to treat the pain early. And I think the most important part of that is to recognize that not all pain is physical. The way the physician, who happened to be a PMR physician, calmed me down when I thought I had broken my wrist, is he said, "Anne, what are you worried about? There's no redness. You need to calm down. What's the problem?" Had I been in my own country, I would have been relaxed, but I was worried. I don't even know how to get an X-ray here in India. I was very worried. He handled that, and amazingly, the pain was gone that afternoon. So try remembering that the next time you have an acute pain. Think about what the emotional amplifiers are, because I think it will really help you understand your patients. I think we sometimes under-medicate pain, and I'm not saying that we need to use opioids, but we under-medicate pain and under-counsel our patients. An analgesic should be given on a continuous basis rather than just at the beginning. This woman, it's quite easy to show empathy. What's the difference between empathy and sympathy?
Depending on their food and understanding their problems. Their food.
Can somebody just repeat what he said, please? Did everybody freeze or just?
Sorry, we can't hear you. I think we lost them.
Okay.
They might have lost internet connection.
Okay, all right, they'll come back.
So, Dr.
Sritu?
Setu or Sharina?
What's the difference between empathy and sympathy? Dr. Sharina, Dr. Sifu?
Empathy is understanding the patient's condition, and sympathy is more of like showing.
I think you're on the right track. Go ahead, Sharina.
But I'm not getting the right words to explain it. So, yeah, empathy is understanding the patient as such, like how he feels and his all aspects, and understanding that and acting accordingly will be empathy. And sympathy is more of like showing. I don't know.
Yeah, I think you've got the right idea. Hello, you're back.
Yeah, we're back. Sorry.
No, that's fine. Glad to have you back. So I think you've got it right. Empathy is walking shoulder to shoulder with a patient, and sympathy is making the patient an object, often of pity. And so I think understanding what walking in their shoes, understanding their situation is what empathy says. Is that what you were trying to say and we lost you? We lost your
Yes.
internet connection? Okay.
Yeah.
All right. I think this is an important distinction, and I am sure that all of you are doing that. Your body language, which you're conveying because you're sitting down, should be leaning in, showing that you care for them. And I think naming you seem to be in a lot of pain is one way to give them a chance to voice what's on their mind. I would say that the most important way for us to handle spiritual pain is to both name it and allow them to talk about what it's like to be them in this world with this very serious illness. So I think that's all I have. Now that we've talked about this, what are you thinking about this patient? Let's just put it this way. What kind of pain doesn't she have? She does have social pain. She does have spiritual pain, I suspect. She has physical pain, many reasons for physical pain, and she could have all of the kinds of pain we talked about. She could have nociceptive pain. She could have neuropathic pain. I don't really see the visceral pain here, but unless she had metastases to a larger organ. Suddenly, her poor adherence to treatment seems like a different kind of message to me, one that I want to explore more. I don't want to scold this patient. I just want to hear more and see if I can unload her of her pain. When in my early career, when I just focused on the physical pain and let the social workers and the nurses handle all the other pain, I ended up using too much opioids. Now that I'm doing a full assessment, I have a far more balanced pain treatment than I ever had before. This is, I'm talking from the the US context. So that's what I have. Do any of you have questions or comments? I hope you have both.
From this presentation, we have learned that about different type of pain, that like somatic pain, neuropathic, physical pain. I think we are quite versed with this presentation, so it helps.
Thank you, ma'am. It was a good presentation. But my question is, do you regularly monitor the side effects caused by the analgesics because of the continuous use?
Do you regularly monitor the side effect of analgesics? Is that the question?
Yes.
Yes. Of course. So it doesn't matter what analgesic I start. If I even start paracetamol or other medicines, amitriptyline, I need to be on the phone with that patient within 2 days to monitor how it's going. So I'd like to monitor for side effects as well as efficacy. So is it reducing their pain? More importantly, are they able to do things that they were not able to do before? So yes, absolutely. Close monitoring is part of this. And I think you're, in subsequent talks, you're going to get which of these medications are started, what their side effect profile is, and what you'll be watching for. I think what this case emphasizes is that when you build relationship with a patient and gain their trust, they will start doing things with you and for you with time. Though I haven't met this patient, I have met this kind of patient in other settings, and I find that they have lost trust in the medical field, and then I'm working to regain their trust due to their poor pain management up till now.
Yeah, one more question. What's the average time you spend for a single patient?
Great question. So in the outpatient OP environment, I'm spending about 20 minutes with a patient doing this pain assessment and exam. Interestingly enough, if you sit down, this moves a lot better. The relationship is built faster. Sometimes these appointments can last a full hour, which I realize in India is often not even a possibility. We use tools. This is what Sharina was talking about. We use tools to have people assess their pain before or all their symptoms, the ESAS tool, before they even walk in, so that helps us with time. Does that answer your question?
Yes, ma'am.
Often the nurse does an assessment first, and that helps. So we have a multidisciplinary team. The social worker often sees the patient and identifies psychosocial stressors.
So any more questions? Are there any more questions or comments? Yes.
Ma'am, when will you decide a patient needs to be taken from OP care to an IP care?
I understand.
So there are two reasons that I decide to bring somebody to inpatient. One is that I have tried 2 or 3 things and I can't get their pain under good control. And so I realize I am failing in outpatient and I bring them in for a pain crisis. I usually try very hard to get pain in my context in the US. I try to get the pain managed outpatient because people tend to sleep better in their own home, and sleep is a high component of pain. So if if sleep is not managed well, if they're in a unit that is very noisy and they can't sleep, their pain will be exacerbated. It will be worse. So I try very hard to get them at home and keep them at home with frequent phone calls. Sometimes I'm calling every day to keep them, to see if I can turn things around. This is a privilege that I have, that I used to do a lot of telephone healthcare, so I feel comfortable doing these phone calls by doing care by phone calls. So I will try to see if I can turn things around at home because it's a better setting for the patients usually. But if I can't turn it around, then I bring them in for intravenous interventions and total team interventions.
One more question. Can you just tell us who all comprise this team, multidisciplinary team?
So I've had 2 different kinds of teams at the University of Iowa. The team involved physicians, nurses, social workers, chaplains. This is not something I've seen as much here. These are chaplains that do not have a specific faith affiliation, but they deal with the grief and spiritual pain. And also we use something called music therapy. This is the use of music to decrease anxiety, decrease pain, decrease nausea, and induce better quality sleep. So that's our multidisciplinary team. It's highly effective. And in my context, the multidisciplinary team has been shown to use less medications. In some cases, people come in for a pain crisis, but they don't get more medicines. They just get the treatment of the entire team, and they get their pain under control with the same amount of pain medicines. It's very exciting to think about using a multidisciplinary team to control pain. And it reinforces that much of pain is not just physical, but also has a social, relational, psychological component. So this is a paper that just came out of MD Anderson. They admit people, they don't change their medications, and the team lowers the pain. Great question.
I see that why did you ask the question when will be an outpatient will be taken for IP care? Was there a question behind that question?
What are the criteria that we have to take into account when we take a patient for IP care? That's what I wanted to know. Is there some specific set of guidelines about that?
So what we say, we have very few beds in my hospital, so we need to rationalize admission. So we say, we've tried this, this, and this, and he's failed outpatient management. We have nothing more to offer. And that's what prompts inpatient admission. So we have to at least try doing the outpatient. And like I mentioned, people in general are better in their homes. As a group, veterans, people who have been at war, prefer not to be in an institution. They don't want to be in the hospital. So when they start begging to come into the hospital, I know they're quite desperate for pain relief.
So you have heard from Dr. Ann that they have a multidisciplinary team. Here also we have a multidisciplinary team which contains doctors, nurses, social workers, physiotherapists, and now physiatrists and psychiatrists now. So we have multiple personnels included in our multidisciplinary team meetings now. But the combination may vary depending on the availability also. But it is important that we get feedback from each of these people, because many patients might have psychological problems, they have mobility problems. So all inputs are important to assess and manage the patient in a whole person setting.
I'll just say one more thing about multidisciplinary teams. Often doctors, we dominate those meetings. It's very important when we started having multidisciplinary teams, we started saying that the doctors had to be quiet for the first 10 minutes, just to make sure that we heard from the chaplain, the social workers, and the nurses. Because doctors, we tend to dominate every situation, and we were dominating the interdisciplinary team meeting. So until the other disciplines got used to speaking up, we had a rule to keep the doctors from dominating too much. Turns out that women doctors dominate just as much as men doctors. It's not about gender, it's about being a doctor.
Any more comments or questions? Okay. As we know, pain is not only a physical sensation, but it is also influenced by many other factors. Not only the emotional factors, but also social problems, financial problems, their spiritual pain, all are affected by pain, and all of this can influence each other. So when we look the patient, our aim is not only to reduce the pain, it is to reduce the suffering and thereby improving the quality of life of patient. Uh, so pain is actually a disability. We can call pain as a disability, and because it interferes with all the aspects of our all the domains of our work or our daily living. So we look at social aspect. Is there a disability in the social aspect? Is there a disability in psychological aspect? So we have to improve the disabilities in these aspects to treat the pain. And it is important to listen to the patient. Usually when in our setting, when a patient comes, there will be a lot of caregivers or at least one. And sometimes we tend to look at the caregiver and ask them about the pain. How is your pain? Instead of asking to the patient. But it is important to ask to the patient because the patient knows how the pain is. So that is one of the most important thing that we all understand. And not only we need to stress on the physical aspects like PQRST, what are the effect on activities of daily living, what are your sleep, okay. So all those things need to be assessed, but also we need to look at their other aspects. But it is we can treat physical pain, but the other aspects of pain like physical, psychological aspect, social aspect, financial aspect, who is going to take care of those aspects is also important. And we understand that there are mainly pain can be divided into two types from a clinical point of view, into nociceptive pain and neuropathic pain. And nociceptive pain can be again divided into somatic pain and visceral pain. Somatic pain are those which arise from the external parts of the body, like muscles, skin, bones, whereas visceral pain arises from the organs inside the abdomen and chest. And each of them have characteristics of pain. Some are very important from a clinical point of view because according to the nature of the pain, we have to select the treatment also. So we will move on to the patient story, which will be presented by Dr. Jijo.
Can I start?
Yes, yes, we can hear you.
Today I'm presenting the case of Mr. Rajan, 53-year-old male. The diagnosis is cerebrovascular accident, left hemiplegia, with an associated left humerine facial nerve palsy. He also has a left shoulder subluxation and chronic regional pain syndrome of the left hands.
Dr. Jijo?
Yeah.
I think we have lost them. We can wait for a couple of minutes. They will be relogging in.
Yeah, Dr. Jija, yeah. We lost you
We can
for
go
a-
to the next slide. Yeah, it's presented to our department with weakness of the left upper and lower limb for the past 18 days. It started as an episode of fever, which was associated with diarrhea, and he was admitted for the same in a local hospital. But during the admission at night, he had a sudden weakness of his upper limb and lower limb. He lost consciousness. There was no associated vomiting or any convulsions. He was referred to a tertiary care level private hospital for expert care. And there he presented about 4 hours after the onset of the weakness, and they did an imaging of the brain. He was admitted to ICU. They withheld thrombolysis because he had a history of blood in the stools. And they started antiplatelets and statins. His bladder was catheterized, trials 2 was inserted, and CT revealed an infarct, which was right-sided, and there was mass effect, the midline shift. During the ICU stay, he had an episode of aspiration pneumonia, and on 10th day, due to some financial constraint, they took reference to the government medical college Trivandrum. And here he was admitted in the medicine ward. They continued the same line of management, and they controlled the comorbidities, that is of diabetes and hypertension. So the patient was stabilized, and they transferred to the PMR department. You can come to the next slide. So after 1 week in medicine ward, he was referred to PMR for further management, and he was admitted here for rehabilitation. So this is the history. When he presented to us his functional status, he was, before the illness, he was completely independent in all his activities of daily living. But after the illness, he had only bed mobility, and he was dependent in all of his activities of daily living. And his functional independence measure score, it comes to 70. You can see that he is very much dependent in his self-care activities like feeding, grooming, bathing, dressing, toileting, and also in transfers and ambulation, he is very much dependent on his caretaker. Next slide, the comorbidities. He has diabetes for the past 1 year, and he was on irregular treatment, also hypertension. He was on irregular treatment, and his bronchial asthma, he was having control with use of an inhaler. Personal history, he was an alcoholic, and the bladder is under continuous bladder drainage. Bowel is continent, and he passes stools once in 2 days, and his sleep is disturbed. In the family history, his father had a similar stroke. There was nothing else significant. Socioeconomic, he was pre-morbidly, he was an accountant in a private firm. And his wife had passed away 8 years back. He had just remarried 1 year back. He had 2 kids, one of whom has a job, and the other is a student. Architectural history, he has an own house, vehicle accessible, and which is an uneven turning. He uses pipe water. He needs to traverse 1 step to enter his house. There are no barriers within the house. The house has 2 rooms. So coming to the examination part, so vitals were stable when we reached our department. Head to foot, he was under a Polish catheter with trials tube feeding. And the CNS, the higher mental functions were normal, and the cranial nerves showed a facial deviation to the right side. Power, next slide. The power, when we assess, the left upper limb and lower limb were of grade 0 power. And other than that, the musculoskeletal system, there was some tightness of his tendon Achilles, and his left shoulder was found to be subluxated. And the local examination, we found an edema of his left hand, and the finger movements, passive movements were very painful for him. And also the shoulder movements were painful for him. Other systems didn't reveal much of a problem, except the respiratory system, the air entry was equal, but there was some bilateral wrong type. So, coming to the final diagnosis. We know the diagnosis, so I'm not repeating it. The rehab issues in this patient, we found out his pain, the weakness, his self-care activities, dependence, the bladder issues, the swallowing we had to assess, and musculoskeletal problems like the left shoulder subluxation, left tendinitis tightness, and also his medical comorbidities. So our immediate goals are to manage the pain and to prevent further complications. The short-term goals are to achieve some kind of sitting balance, and then if possible go on to wheelchair ambulation and then bipedal ambulation, and attain some independence in his self-care activities. And the long-term goals are to achieve vocational rehabilitation and recreational investigations. But routine investigation did not reveal much of an issue. The CT, as I said already, showed a large right middle cerebral artery infarct with a mass effect. Treatment, we continued the medicines, the antibiotics for controlling the chest infection, diet modifications, and they started a stroke rehab program. The team members were a physiatrist, the rehab nurse, the physiotherapist, occupational therapist, and an orthotist. So I'll just give a summary. The medical management was continued with antiplatelets, statins, and bronchodilators. In physiotherapy, we gave a graded tilt-tabling, passive range of movement exercises, sensory stimulation, and oromatral facial activities. In occupational therapy, they gave a self-care training activities, transfer training, sitting balance training. To manage the chronic regional pain syndrome of the left hand, we used pain modulators. We gave a wrist block. We applied physical modalities like transcutaneous electrical nerve stimulation, contrast bar, and mobilization. And for the left shoulder subluxation, we gave a shoulder support and with electrical stimulation to the deltoids. And left tender Achilles tightness, we just gave a stretching and nighttime splinting. And gradually, we weaned off the catheter, and also the Ryan's tube, we gradually weaned off. So at discharge, his vitals were stable, general condition was good, the comorbidities have been controlled, our bladder was continent, and he could take few steps in the parallel bar with a support. You can see the film has improved from 70 to 90. So that's about the case. Regarding the psychosocial aspects, he was the major breadwinner of the family. His son did not have a permanent job yet. And so their education and job of his sons were affected because they had to care for him. He was a religious person, but now he's unable to go to church. And there were some domestic issues with his wife. His wife left him in midst of the rehab program. And before the illness, he used to spend time with his friends for recreation. But so now his recreational aspects were also affected. Medication, we have already discussed the antiplatelets, statins, antihypertensive, so oral hypoglycemic agents and pain. The main concern after discharging, we will care for him at the home. Can he return to his job? Will he be regular with his follow-up and financial issues in his family? To summarize, it is a 53-year-old male. It's stroke, left hemiplegia. He has partially recovered, has multiple comorbidities, has achieved limited bipedal ambulation with an orthosis and a walking aids. So discussion, I think you can decide. What I put is a loss of follow-up, providing care at home, the barriers for him to return to job, and how to regain the financial stability of his family. Thank you.
So thank you, Dr. Jijo. So we have a middle-aged man who sustained a CVA and became veteran, but by the time he was rehabilitated, he was able to walk in parallel bars. So the main problem, there are a lot of comorbidities as well as psychosocial problems. One is about how to follow up the patient and how to return to his job and stability of family. So, do you have any more questions to clarify?
I have some questions about the FIM form. What does that stand for and how do you use that?
In PMR, we are more concerned about the functionality of the patient. So one tool to assess it is a functional independence measure scoring system. It's called the FIM score in short. So in that, you will take 18 activities of daily living and we'll score them from 1 to 7, where 1 denotes complete independence. That is 100% dependent on the caretaker. Complete dependence on the caretaker, score 1. And score 7 is complete independence. He can do the activity by himself. So we score him from 1 to 7. Maximum possible score is 126. Am I clear?
Yeah, no, very helpful. Thank you. And my other question was, how did you treat the pain, and was a TENS unit successful for his shoulder and hand pain?
TENS, it initially was effective, but later on it was proving to be ineffective. He was requesting frequent sessions of TENS. So we went for a wrist block, sympathetic blockade at the wrist for the chronic regional pain syndrome of the hand. We gave a suprascapular nerve block for the shoulder pain. And along with that, we did a mobilization. And gradually, we attained somewhat pain control.
You used paracetamol, or what did you use for pain modulation?
Initially, we started with a non-steroidal anti-inflammatory drug, aceclofenac. Then gradually shifted to a pain modulator, amitriptyline and gabapentin.
Amitriptyline and gabapentin. Okay, so we know that this is a great job that you have done for this patient. But once the patient is discharged, then the mechanism of follow-up will be little bit difficult for you, isn't it?
Yes, it will be not easy for us to follow him up.
So, have you been doing any tie-ups with anybody till now? Or
Not yet. If we know a local PMR doctor, we usually ask the patient to consult him, but they are very few in number.
Yeah, that's correct. So the problem with these patients are with the limited mobility, they will not be able to go and see the doctors to the hospitals. So it will be better if you can join with or make some attempts to contact the local palliative care teams. Because there are palliative care teams in each primary health center. There will be at least a nurse. So they will not be doing hi-fi things, but they can monitor those things what you have already told them. So if you speak personally to this nurse, then it will be better. They will be able to follow up better. And in addition to the government system, there will be NGOs like us who will also be willing to help the patient. This patient, there is no Riles tube and Hollis catheter, but many of those patients has catheter and Riles tube. So that has to be changed frequently. These all will cost much for a patient. So it is important to make some tie-up or some calls to the local palliative care teams, and they will be able to help you. And thereby the patient will be benefited because you have started something and you have attained something. Then after going home, that is not followed up, so that the patient's condition is going to deteriorate. So if uh, if you make these people also aware about what to do and things like that, then the patient condition may gradually improve. That's what I have to tell about the follow-up and providing care at home by palliative care teams. Palliative care teams will be visiting these patients, but I think it will be important to give specific instructions which can be followed up by these teams.
Yep.
And if you want to get the contact, it is there. The NGO's contact will be there in our website. You can just Google it and find out where all there are NGOs. There will be phone number also.
Okay.
So the other problem is with the family. The wife left the patient. So what was the problem? Why she left?
Patient actually assaulted her.
Okay.
When he got frustrated, he assaulted
Okay.
her.
And do you have social workers with you?
Yeah, we have.
In your department?
Yeah.
Okay, so I think how many social workers are there?
Sorry.
How many social
Yeah,
workers?
just one.
Okay, so if the social worker can play a major role in such situation, because this problem with the patient and wife might be this happened suddenly due to some provoking something. So if that can be talked between them, there is a chance that they may come into their lives again. So these are some situations which we usually face here, and our social workers take care of these situations. So that's what I feel about the family situation.
It's an awfully nice outcome for this person, but he is still at high risk for another event, myocardial infarction, another stroke. Seems like you've reduced risk factors with statins, aspirin, but he's still somebody who has diabetes, alcoholism, still at high risk for another event of some kind. And the more supports we can put in the home, maybe the more likely he will, not have a repeat major event again. It would be sad to see him back with a myocardial infarction from his uncontrolled diabetes at this point.
Who all are there in this patient's family other than wife?
Two sons.
He has two sons.
Married?
No, unmarried.
Okay. I think I don't know because both are young individuals. Most probably they will not be at home, and they may not be able to take care of the patient also. So his diabetes and hypertension is going to most probably it is going to worse. Even if previously also he was taking irregular treatment from your history. Now with his limited mobility, this problem is going to be more. So the controlled hypertension and diabetes is going to be a problem, which can add to, as Dr. Ann told, maybe can end up in myocardial infarction or recurrence of stroke. So it is more, it is all important that we should have some local contacts. So with whom this patient went? With his son?
With his son.
How old are they? Any idea? Think we lost them.
I think the other thing illustrated by this case, for those who are still on, is that palliative care will focus on the whole family. Oh, there you are. The patient who is in pain or has this major event is not the only focus. We're also focused on the son that may have dropped out of school in order to take care of his father, or the son who lost his job in order to take care of his father. These are people who in palliative care here in India and in the US the whole focus is going to be on the family, on the whole unit, both the patient and his family. And even though the wife left, I think that Dr. Sunil's point is that we're still going to focus on her as well, because she's obviously part of the unit of care.
Are there any comments from any of the participants? Nobody? Okay. So, Dr. Jijo, from next session onwards, can we get patient stories of palliative care patients? These are palliative care patients, but mainly concentrating on the physical aspects or physiatry aspect of palliative care. So, I know that many of you may not be knowing that there is a palliative care OPD at the medical college every day from 1 to 4 p.m. In the in room number 121. So you can go and see the patient and get patient story from there, so that we can discuss more on palliative care aspects.
We have actually academics during that period.
1 to 4. Okay. So even there are inpatients. So the inpatient consultations are coordinated by Dr. Babaraj, who is the additional professor of anesthesia. So he see palliative care consultation. So if any of you are willing, I can connect you with him so that you can get patient stories. Okay, I will give you the contact number of Dr. Babaraj. So for this patient, it is from palliative care point of view, this patient needs a lot of psychosocial interventions, and the help of local volunteers is what is needed for this patient, especially because the wife has left him. So if there are some volunteers who is willing to take care of him, may not be full time, but frequently comes and goes and do the needful, then that will be helpful for this patient. And I request you to make an attempt to find out local palliative care units, which will be helpful for following up these patients. Anything else?
No,
Okay.
thank you very much.
Are there any more comments or questions? Okay, so I think we will end this session, and thank you, Dr. Ang, for being with us, and thank you, Dr. Jijo, and all the participants for being with us for today's session.
Thank you all for joining in. So we can see you on next Thursday with a topic on management of pain and a series taken by Dr. Mary Abraham. So I have shared the feedback link. Give it a minute, do it, and only leave the meeting. Thank you all for joining in. See you next Thursday. Bye.